So this is Jacked Up Politics. We're taking a bit of a break from all kind of political related stuff for this week's episode, and we're joined today by Dr. Hugh Doran of East Cork Rapid Response, who is the primary responder for East Cork Rapid Response here in East Cork. And we're very happy to have him on the show. Dr. Doran, thanks so much for coming on.
Well, thank you for having me on, Jack. Thank you.
It's a pleasure. It's a pleasure, Dr. Doran. So, for anyone who might not know what ECRR is, ECRR is a charity organisation that responds to the most critical 999 calls within the East Cork region and within Cork itself. And it is manned by volunteers throughout the year, and they respond to the most life-threatening incidents, assisting the National Ambulance Service and the Irish Coast Guard in their duties as medical providers. So, Dr. Doran, thanks for coming on. I just want to start off by asking, how has 2024 been for ECRR so far? Has it been busy? Has it been quiet? Or what's been like for you this year so far?
Well, Jack, it's been quite busy. We went through part of the summer where we had a lot of calls, and but the average has been around about 9 calls per month, and that's fairly steady. The character of the calls has changed. Unfortunately, we're seeing more incidents such as stabbings and violent episodes. We've also had, the usual road traffic collisions, industrial accidents. So, yeah, it's been a busy year as always.
And I just kind of want to kind of ask, I want to ask you as well, have you kind of seen a more kind of like, I know over the summer you were just mentioning there that we've seen more violent incidents. Have you kind of seen a kind of spike in violent incidents over the last few months, or has it kind of been a steady increase?
Well, I think my experience is there has been a steady increase. When I first started this kind of work, which is long ago and further than I care to remember, a stabbing incident was very, very rare. And in the last year, I've responded to 4. 3 of which have been fatal. So yeah, there's a steady trend upwards towards this kind of incident.
And so I just want to ask you as well, like, how did you get involved with emergency medicine? Because emergency medicine, for those who don't know, is probably one of the most tricky fields in medicine, because you have to deal with quite a lot of blood, gore, and mainly stuff that a lot of people wouldn't be comfortable dealing with. So I know you're a GP yourself, and I kind of want to find out how you kind of chose kind of like trauma and emergency medicine as a GP.
Okay, well, I suppose my influence was mainly from my father, who worked here. He worked in the UK and came back to Cork in 1970. And we just found that, there was a lot of trauma in East Cork, and at the time the surgery was in the house, and you could have anybody in any state of crisis walking in the door at any time of the day and night. Road traffic collisions, some positive things such as emergency childbirth. So I suppose, I didn't lick it up off the floor, and I was inspired by his work. And he developed things from a simple first aid kit up to a response vehicle, which at the time was a Range Rover, equipped with a defibrillator, and that was in 1981.
And I think we've come a bit away since 1981, because now I think you're driving it's a pretty new Land Rover Defender with myself at some of the emergency services open days. And Dr. Ron, I must say that vehicle, it's like a mini emergency room on wheels with the amount of equipment you have in it.
Yeah, well, I'm very fortunate to have this vehicle. We've had many over the years, and I suppose it's only in the last, say, 12 to 15 years that the fantastic charity and the work of people like Jean Marsh and others have taken the financial burden off the practice. And now we are, a declared asset to the National Ambulance Service. In fact, we've been responding to their requests since 1995, when I started in general practice here. The equipment has developed, as I say, from fairly basic stuff right up to the present day, where We've just taken delivery of a new ventilator. We have a state-of-the-art defibrillator and cardiac machine. So we can actually, to use that term, put people on life support at the side of the road, in the house, and whatever other situation they get into difficulty.
And I think what's so brilliant about ECRR, and I know we're very lucky in Cork as well, we have West Cork Rapid Response as well. That's mainly under the care of Dr. Jason van der Velde, who, for those of you who don't know, is an medicine consultant based up in CUH. And Jason is another fantastic doctor that I hope to have on the podcast in the next few weeks as well. And I think we're very lucky, Dr. Doran, to have such high caliber doctors responding to 999 calls in the Cork region. And there's a question I have for you now, Dr. Doran, if you don't mind, is how do you find responding to these 999 calls? Is there a sense of trepidation when you're responding? Is there a sense of urgency to get there? Or what kind of a sense do you feel when you're responding to these life or death calls?
Well, yeah, that's an interesting question. When the call comes through, either by text or by radio or by phone, we just get a designation as to what type of call it is. There's a coding system which is used by NEOC, which is the National Emergency Operations Control Centre, and they dispatch the appropriate resources to an instant. And you just have to sort of, keep things together, try not to panic, and try not to allow, as they say, the red mist to take over. So while driving in the response car may look very dramatic and sound very dramatic, quite often we're actually driving at almost walking speed through traffic. So then, if we know what kind of call it is that we're going to, we would be going through a plan in the head, with not getting distracted in road conditions, to let's say, use the usual priorities for assessing any emergency medical situation, be it pre-hospital or in hospital.
And I just want to ask you, if you get a challenging call, which I'm sure you get many throughout the year, how do you kind of process and deal with the kind of severity of the call afterwards? Because I know I have quite a few friends of mine who would listen to the podcast are medical students, so I just kind of want to give them a bit of advice per se on how to kind of deal with traumatic incidents, if you don't mind, Dr. Doran. Sure.
First thing is we don't take these calls home to our families. A hot debrief, either in the hospital, if and when I travel in with the patient, or with colleagues in the pre-hospital sphere, or when I work in the CUH in a session in the emergency department, we would often just chat amongst ourselves and debrief. But you tend to compartmentalize these things, and like I've been doing this kind of work since 1975, so you kind of develop an informal strategy for just going on to the next call. And one of the best foils for getting over a stressful and traumatic incident is actually routine and going back to work to see the next patient or the next session or whatever it is.
And I know in Cork, where it's a very large county, right? Like, we're the largest county in Ireland by terms of area. And for people, a lot of people don't realise that for East Cork Rapid Response, you're kind of I'm home to correction on this now, Dr. Doran, but I'm sure that I think your area responsibility goes from, is it around Glentown in the west all the way over as far as Youghal in the east, and maybe up as far as Fermoy in the north?
That is true, but as with the National Ambulance Service, it's a very flexible service, so resources are no longer planted in one place, such as back in the 70s when the ambulance in Middleton would have been under the control of the matron of the Middleton Hospital, and that was appropriate then. But now we have resources that may be deployed elsewhere. So I've been as far as into Cashel, I've been as far west as almost into Waterford, the east, I beg your pardon, and also as far down as Skibbereen, helping out Jason or being there in his stead when he's away, being into the city. So it's very flexible, and the area of operation just changes depending on the incident involved.
And I know with with thankfully thanks to the new Aeromed 01 and 02 assets based out of Rathcoole in North Cork. I I have a question for you about those, if you don't mind, Dr. Doran. Would you respond on those as well, or is that just paramedics on those?
Well, I have worked with the Heli Med service, both from the Air Corps based in Athlone, the Coast Guard, who have a service level agreement with NAS, and also on formerly Heli Med 92 and now Aeromed 01. Been lucky enough to do some observerships on the Rathcoole-based helicopter. And there's work going on with Professor Adrian Murphy to actually look at the feasibility of having physicians on a structured basis on the aeromedical service. Sometimes I would go to a scene by road, and depending on the the incident involved, such as a road traffic collision, I may get on board to help look after the patient during transfer to Cork, and that's happened quite a lot.
I think your job has been made slightly easier this week now with the opening of the new helipad in CUH, which I think is a big relief to not only the National Ambulance Service, but I'd say the Irish Coast Guard and the Air Corps as well, because that now means that you can get a patient from the helicopter into CUH a lot quicker.
Absolutely. It's a real game changer and a huge advancement in trauma care in the Munster region. And the pad is big enough to take all the various different types of helicopters. The Coast Guard are now transitioning to AW189s, very, very efficient and brilliant aircraft, to be honest. So yes, it's a game changer, because quite often if you had a case reasonably close to Cork, you'd have to gauge whether it was going to be time efficient to actually take the patient by air, because you had a transfer at the other end and a road journey to the hospital. And now with the helipad there, and in the future a covered walkway, we should be able to go from helicopter to ED resus room within a matter of minutes, which is an absolutely wonderful development.
Definitely. And I think we're very lucky with the pre-hospital care that it's come on leaps and bounds in the last 10 to 15 years, because I know myself, unfortunately myself, I've had to be taken to hospital a few times myself by ambulance, and I was always grateful for the lads and the ladies in the National Ambulance Service that we have here in Cork. They're some of the finest guys and girls in the country, in my respect. And you're like yourself and Dr. Vanderveld, Dr. Doran, we're very, very lucky to have you. And if you don't mind me asking, how has the pre-hospital emergency medicine come on, even in the last 10 to 15 years, compared to, say, the early 2000s? How has it kind of come on, like, recently? Because I know there's now, lately, we're very lucky to have the likes of the Zoll Auto Pulses, your Lucas devices, and your Zoll X series that now are nearly like a third and a fourth crew member at the scene of an emergency.
Absolutely. I'd go back further to the mid-70s when, in 1978, the CUH opened up. It's the busiest emergency department in the country, currently seeing over 65,000 patients per year. And in terms of development of pre-hospital emergency medicine, we've gone from having a vocationally motivated person driving the ambulance, staffing the ambulance, to now having people who are, they are graduates of UCC, and they also have higher qualifications such as masters in science, and also some PhD candidates. So the caliber of the people has always been excellent, but it has, the knowledge base and the training has gone towards the sky. It's absolutely fantastic to see. And I was lucky enough to be involved in the initial cardiac training back in 1991, 92, when the first defibrillators were actually introduced on the then Southern Health Board ambulances. And that was another great step towards improvement of care.
Now, this is a question I have for you as a doctor of emergency medicine and as a GP, it's where would you like to see paramedics going in the next 5 to 10 years, and even emergency medical technicians? Because I know myself, the title of advanced paramedic is kind of being rolled back slightly, and it's now being replaced by critical care paramedic and specialist paramedic. So I might just get you to talk a bit about that if you don't mind, Dr. Doran.
Sure. Well, yeah, the role has been subdivided into, as you say, critical care paramedics, some of whom are in training already. Excellent people. I've worked with them both on the ground and in the air. We also have the introduction of community paramedics, and I'm involved in that training, which is a great privilege and a huge, asset towards primary care. And I think that, supportive primary care would certainly take a lot of pressure off the emergency department and indeed the ambulance service. It's good that we have free access to emergency transport and care on the 999 112 call-out system. But sometimes, unfortunately, like any service, it can be used, but unfortunately abused.
Yeah. And I think there's like, I know I have a good few friends of mine that are paramedics, and one of the biggest things they say to me is, Jack, look, you don't even realise half the amount of hoax calls we get during the week, or someone that rings 999 because they can't get a medical appointment and stuff like that. And I think the introduction of community paramedics, Dr. Dorn, will be absolutely fantastic from my own point of view, because I think that'll kind of help the general practitioners such as yourself with your workload, and I think the fact that now we'll have these community paramedics coming online, I think, is it in early 2025? I think they're to come.
That's correct, and we'll be starting the GP attachment very shortly now in East Cork, and I look forward to that immensely. They are an amazing bunch of people with, they're highly committed, highly experienced, because they've already been working in the National Ambulance Service for some time, and their input. I previously had two excellent people a couple of years ago in the initial phase of community paramedic introduction, which sort of was put on hold for a while. But the two people who worked in, being trained by us, and also then worked in the practice 1 or 2 days a week, it was fantastic, because they could deal with so many things, such as going out to a house, catheterizing someone, saving that person being transferred to, say, the emergency department for treatment.
I think as well, like, what a lot of people don't realise in Cork at the moment now is they're phasing in what they call the Pathfinder service, which is basically an advanced paramedic and either an occupational therapist or a physiotherapist that responds to low acuity 999 calls to try and reduce the amount of people that are presenting by ambulance to the likes of CUH and the Mercy. And if you don't mind me asking, Dr. Doran, how do you think the Pathfinder service is benefiting you as a GP, your patients, and the National Ambulance Service as a whole, if you don't mind me asking?
Well, I think the Pathfinder service is a great asset, because, as you rightly say, the service will actually help to deflect people from being transferred to hospital and sorting out problems in the community where, they can be done with safety. The other service, of course, is the app car, as we call it, which is staffed by an EMT and one of the specialist registrars in emergency medicine from Cork, and they are very flexible. They have a dual role in assessing and treating people on scene, discharging them in their own homes, or sometimes being diverted to critical care calls. So they are a wonderful asset.
And is it very possible to believe that once community paramedic is fully integrated with HSE, because I know it's kind of in its initial operating capability phase at the moment, is it very plausible to think that in the next 3 to 5 years we could see more Pathfinder vehicles on the road, but instead of having, say, an advanced paramedic on board, we'd have a community paramedic on board with a physiotherapist?
Yes, I think that's the plan, and I would be very hopeful that will come to fruition. If I just reflect on my GP colleagues and the GP service, all of my colleagues in East Cork and elsewhere obviously work extremely hard. And for out of our service, I was involved in the setting up of South Dock for the East Cork area. 25 years ago. But unfortunately, resources are tight, and we've gone now from having 3 centres of practice, the out of hours service in East Cork, down to 1. And in fact, we don't even have a response car, whereas we did have 2. We don't have a response car for doing domiciliary calls. That responsibility lies with the car based in the city. So there's been a rollback and a reduction in the available resource in terms of primary care, directly linked to myself and my GP colleagues.
Because I know my own mother in 2014, she got very, very sick, and it was I remember we put in the phone call at about 5 o'clock in the morning to South Dock, and it was basically a doctor from Middleton. He was an older South African doctor, very nice gentleman. Responded to the call, and it was what struck me about that, Dr. Doran, was the fact that this gentleman came in treating my mother with the utmost respect and was able to kind of advise my dad on what the next steps needed to be. And I have to say as well that South Dock, I know quite a lot of people kind of have their own opinions on South Dock, that it's not fit for purpose and all that jazz. But I think what a lot of people don't seem to realise about South Dock is that they're very understaffed at the moment. They're very caught for staff, and that their workload has increased nearly 5-fold over the last 10 years.
Absolutely. I would agree with all that you've said about the out of hours service. We're also seeing the development, or the appearance, shall I say, of some other primary care services, some of which are very good and will communicate with the GPs, and others who don't, which is a safety issue that I would have. But yeah, I think that, as I said at the beginning of this, primary care, properly resourced, can be a huge asset to, preventing overload of all the emergency services, both pre-hospital and in-hospital.
And I know this is actually a very recent story now, is my own mother is she's recovering from cancer at the moment. And thankfully she's on the other side of it. But during the week she wasn't feeling great. And I have to give a big shout out to Dr. Harry Kelleher, who's a local GP here in Cove. And Dr. Kelleher, even though he was finished his shift at 7 o'clock on Monday evening, he still came out at around 9 o'clock and checked out my mum, and kind of was able to kind of give her further what's the word here now? I'm sorry, brain's gone too much, Dr. Doran.
Treatment, I guess, or reassurance, maybe.
Instructions for treatment, and thankfully, thanks to Dr. Kelleher's brilliant clinical skills, Mom's now getting the best possible treatment thanks to Dr. Kelleher. But I just kind of wanted to get back to what you were saying about primary care being quintessential in modern Ireland. And I just wanted to use my own example of how my own GP was able to kind of come out, even though he was finished his shift and a lot of other GPs would have gone home by that age. Dr. Kelleher came out, kind of talked to my mum and said, look, we need to get a further assessment on this. Age to call, and got the referral. And I think that's just incredible in 2024, that while a lot of people are complaining about GPs, you have GPs like yourself and Dr. Kelleher who go above and beyond for their patients.
Yeah, well, I know Dr. Kelleher, and he's an excellent GP, and as you say, highly committed to his patients. I suppose both he and I are kind of from an older model of general practice, where the GP was part of the community, and people would turn up to the door at any time of the day and night. I suppose what I would say about the newer GPs coming along, who are all excellent, they have probably a better work-life balance than old dinosaurs like myself.
I wouldn't say you're an old dinosaur now, Dr. Doran. Maybe experienced, but not an old dinosaur.
Well, that's very kind of you to say that. I think that you know, general practice in Ireland, the north of Ireland, and also in the UK, it's quite unique almost in Europe, and certainly a completely different model to that found across the Atlantic in America, where many American patients who I would see here when they're traveling would be quite envious of. So I think, general practice and directed through the Irish College of General Practice, fantastic body, it's something we should savor and preserve.
Definitely. Like I know myself, lad, this is going back to March 2023. I was up in Galway with an event with the Rovers and UCC, and I hurt my knee. And the thing was I'm prone to leg injuries on my left leg, and I absolutely did serious damage to my knee that weekend. And I remember going to Weststock, and this is kind of tying back to what you were saying about American patients and the about American healthcare being miles below what Irish and European healthcare is. And I remember I was sitting down in Weststock in Galway, and I remember there was an American lady and her husband were sitting across from me, and she was complaining of being very, very ill. You could see it was as grey as she was as grey as a ghost. And I was kind of chatting away with her anyway, and she was going, "Oh, do you know how much this is going to cost?" And I said, "Oh, it's only going to cost €55 because it was €55 to go and see Weststock at the time."
Yes.
I remember telling her it was 55 quid, Dr. Doran, and you should have seen her jaw hit the floor. She couldn't believe how cheap it was. She goes, €55? And an appointment to see my doctor for that, or my family doctor in the US for that. She couldn't believe how cheap it was. And then we told her afterward, I kind of came out afterwards, and she was still waiting to be seen. And she said, she said, "My dear," she said, "I have another question for you. Do you know how much the medication would be?" And then when I told her how cheap the medication was going to be for her, she was like, "I might move there." And she turned and goes, "I have to move to Ireland." She said, "The healthcare is a lot cheaper."
That's an amazing story. Yeah, absolutely. It brings me back to a story way back where a transatlantic jet was diverted to Shannon, and there was an American doctor on board. And when he'd finished treating the patient, as she was being taken down the steps and loaded into an ambulance, he sort of ran towards the opening in the door and said, "Hi, sorry, can I have your visa details?" So there's very much a different model of primary care here in today. Now, that's not to say that the trauma care in the States in many centres is absolutely, fantastic, and they are world leaders in providing trauma care.
And I worked in America in 2018, I worked in a summer camp with disadvantaged kids, and this was a bit of a precursor to me getting appendicitis in 2020 when I had to have my appendix removed. I got a bit of a niggle where my appendix is in 2018, and you probably know what appendicitis, Dr. Doran, is. Sometimes when you get before the appendix ruptures, you kind of get it a few times beforehand, but it's not as bad. But it's like this very bad, dull crap in like your stomach, and it's very debilitating. And I remember going to see the nurse in the summer camp, and she was a lovely lady, and she put the thing in my ear anyway, and saw that my temperature was about 38.5. So she goes, "Yeah, you need to go into the primary care centre." Now, thankfully, it was very, very close. And I remember we went in, and I was driven in anyway, and I was sitting down in waiting in this like clinic to see the doctor. And I remember the first question out of the receptionist mouth was, "Do you have insurance or are you paying?" And I went, "Oh, I have travel insurance."
Yeah.
Afterwards, right? And for me to go in and see that doctor, for him to do a blood test, for him to do basically check my temperature, do basically what my GP in Ireland would do, and prescribe me an antibiotic and some pain medication to kind of help with the stomach issue. It was $2,500, and I could not believe how expensive it was. I still think I have the bill somewhere, and it was $2,500. I think it was something like $500 for an attendance fee to see the doctor. It was something like, I think, was it something like $1,500 dollars to be 3 hours, and then I think it was something like another $500 then for the medication. It was crazy expensive.
My God, that is hugely expensive. And I think that, I mean, in a way, sometimes I sort of um, and I get unhappy about the fact that we have a two-tier system in Ireland, private versus public. It would be much less complex if we had a system a bit like the NHS, but I don't think as a country we can probably afford that at the moment. I certainly don't think that people should be penalised because they can't pay.
Oh, and like, um, this kind of brings me back into my next question is kind of like, we're seeing a lot more private ambulance companies coming on stream now. And I know and this isn't me slating any private ambulance companies because I've worked with quite a few of them over the years in various capacities, either as a student or administrative roles or stuff like that. And what I've learned with is in Ireland, we actually have a very high standard of private emergency um, healthcare providers, such as Medicall and the likes of ESTI up in Dublin and even Medifor up in Dublin. And
So
we're very, very lucky with the kind of high caliber clinicians that even the private services in those ambulance services have.
absolutely, I agree totally. And in fact, I know many, having worked some of those services, even back in the day, staffing private ambulances. A lot of the people who either create, staff, and run these services are graduates of the National Ambulance Service, and so the caliber is extremely high.
Mm. And this kind of brings me on back to being paramedics and stuff like that. Like, I know every couple of years, FEC, who is the Pre-Hospital Emergency Care Council, for those of you who don't know, and it brings out new clinical guidelines for like paramedics, EMT, and advanced paramedics, which will now become critical care paramedic, specialist paramedic, and community paramedic, which I think is brilliant. But Dr. Doran, what can for any paramedics or EMTs that are listening into this episode now, because I know there will be quite a few listening in, what will they be able to see coming down the tracks in the next 5 to 10 years in terms of kind of like abilities that they'll be given to do? Because I know Better kind of pushing now at the moment to kind of update the kind of paramedic scope of practice to kind of bring it more in line with what a advanced paramedic was. So that way then they'd like to your critical care paramedics and your specialist paramedics will kind of concentrate on their niches while paramedics kind of deal with the kind of more generalized stuff, while you have the EMTs as well being upskilled to possibly what paramedic use or what paramedic is at the moment. Try and give a more cohesive care model.
Absolutely. I think the whole service with individual subspecialties within the paramedic group will just advance the treatment level, nationally, and over time develop more skills and provide an enhanced level of care for all the patients that they come in contact with. And, I go back to the community paramedic system. I think is an excellent one. I've worked with some of the critical care paramedics who are in training, and their skill sets and their knowledge and their ability to manage a scene and support all of us who attend these incidents is just invaluable. Absolutely.
Mm. And I know as well that you're very, very you're very, very busy with the whole ECRR kind of thing, and like how I just want to ask you, how many hours a month would you spend responding to 999 calls, just for kind of someone that's considering taking up emergency medicine as their kind of field of specialty or specialized field?
That's a good question. It varies from month to month. I mean, on average, about 9 call outs per month. It depends very much on what the call out is, as to how long one would, be on that call. It could be as little as half an hour, or it could be, 2.5 hours, particularly. Well, to give you an example, I recently had 2 deal or look after two traumatic brain injuries in one morning and one afternoon. And the second patient was injured in an agricultural setting. So we actually anesthetized and ventilated that patient and actually took him to Cork. So that was 2.5, nearly 3 hour call out. So it's very variable. You can't sort of say on this week I would do X number of hours. It varies from week to week.
And this kind of brings me into my next question is mental health related issues. Have you kind of seen a spike in mental health call outs over the last number of years, or have mental health call outs always been high for the work that you do as an emergency response doctor?
Yeah, well, if you look at the context of primary healthcare, the figures are quite similar here and in the UK. Over there, they say 2 out of 5 patients. Here we see, say 4 out of 10 patients who attend primary care would have some degree of mental health problem, be it from mild anxiety all the way up to psychosis and severe depression. What I can say is that looking at the text alerts I get for a 50-kilometre radius from my centre of practice, is that we're seeing an increase in the number of young people who are having psychiatric problems. Certainly since COVID came along, there has been an increase, and unfortunately we're seeing call out text such as deliberate self-harm in 11 and 12-year-olds, which is very sad and something that needs to be grappled with, I think, urgently. And I know that the pediatric child and adolescent mental health services are hugely under-resourced at the moment. Having said that, they do a sterling job in protecting these young people.
And I think the psychologists and psychiatrists that do work for CAMHS, I'm very privileged to know one of them, Councillor Liam Quaid, who's a psychologist for the HSE down in Middleton. And Liam would be a good buddy of mine from the Social Democrats. And the work that Liam's done for the young people down in Middleton is absolutely phenomenal. I've never seen someone advocate for CAMHS as much as Liam has.
No, it's absolutely fantastic to have him in this area. And unfortunately, if I go back to the noughties and the 90s, we did have a peak of deliberate self-harm and unfortunately suicides amongst younger people, late teenagers and early 20s. And I sort of well up into double figures, unfortunately, of dealing with cases, not only for the National Ambulance Service, but some of the forensic work that I do for the An Garda Síochána.
And this kind of brings me into kind of forensic work now. You're after and the Gardaí. This kind of is something I want to bring up as a public safety announcement. Is I've recently heard a big push on the guards, and Dr. Van der Velde himself have kind of been encouraging people more to not be looking at their phones while they're driving. And because I know that distracted drivers are one of the highest causes of road fatalities and road traffic accidents in the country. So I just kind of wanted to ask you a small bit about what, in your own words, what percentage of road traffic accidents that you have to attend have been caused by someone not paying due care and attention while they were driving?
Well, I think it's one of the commonest causes, inattention due to, daydreaming, trying to pick something up off the floor. Being on the mobile phone. I was actually crossing the road last week in Glounthaune, and as the pedestrian traffic lights turned green for crossing, a driver on his mobile phone drove through the red light, and if somebody had stepped out, there would have been a serious incident. So yeah, it's hugely important that people just use a bit of common sense. So distracted driving, for whatever reason, is a huge cause of accidents. The other thing is that driving under the influence, about 38% of fatal accidents in Ireland involve the use of an intoxicant. And, when I first started doing this work so many years ago, you would see alcohol as being the sole substance of abuse. And the last, I'd say, 10 cases that I've been to would mainly have been either nitrous oxide, cocaine, or cannabinoids, or other stimulants.
Because I remember, I'll just give you a bit of history about myself. I used to be an emergency first responder with the Irish Red Cross up until around 2018, and then I left, doing my own thing. And one of the biggest things I always found strange with people going on nights out was the high levels of people that are using nitrous oxide, which I know myself is very, very dangerous to be inhaling, because it's basically pure nitrogen. It's 50% nitrogen, 50% oxygen. And I think, is it something over, like, if you inhale something that's over 30% nitrogen or something like that, it can actually be fatal to or cause irreversible brain damage, because it can cause a hypoxic event. And another thing was the high level of cocaine usage in young people. That, when I was in EFR years ago, Dr. Doran, was scary.
Yes, absolutely. The thing about nitrous oxide as well is that it is it has the potential to cause cardiac arrhythmias, and in fact, that can be another cause of fatality in people who use that. It's just mind-boggling to see the level of cocaine use. We had a case in the CUH, I think it was last year, a 19-year-old who came in who'd had a heart attack because the cocaine constricts the coronary blood vessels supplying the heart, and he was very lucky to survive. So people are blissfully unaware quite often of the possible effects of using all these substances.
Like, hearing that a 19-year-old had a heart attack because of the sheer volume of cocaine he must have done, like, it must have been staggering to cause a cardiac and myocardial infarction.
Yeah, it must have been, but also you can get idiosyncratic or patient-specific reactions to relatively low levels of these substances. So it's not necessarily dose-dependent. So beware. If you take these substances, then you're at risk. End of story.
Because I know myself that, like, I've heard stories from paramedic buddies of mine and EMT buddies of mine of MDMA overdoses at music festivals, and basically doctors having to put in IVs and use chill saline to try and bring down someone's body temperature, because and this is a public safety announcement to anyone that's listening to this now, and this comes from several AAPs and several paramedics and several EMTs that I'm very good friends with, that they've said that the amount of drugs that were at music festivals this year was unparalleled, and it was really high compared to years gone by. And a buddy of mine was saying to me that they had to rush a 21-year-old male to hospital because he had had an MDMA overdose. And he said to me, Jack, if you ever take an MDMA overdose, he said, it is probably going to be, and if you don't get treated, he said, it's going to be the worst possible death you could ever give yourself, because he said you are going to cook from the inside out. And that's kind of something that scared the hell out of me.
Absolutely. I have in the past covered some musical festivals, which I will not name, but the level of drug abuse and usage was absolutely frightening. I mean, the medical services were set up so we had, I think, 3 resuscitation bays at the same level of care as you would find in any emergency department, and they were in full swing. And we had one patient who was very close to being put on a ventilator and intubated. When she came round, professional lady, she said, "Gosh, this doesn't usually happen," and we were all gobsmacked that this is something that she does from a recreational point of view, or did at least, at that stage. And you've got young people who are completely knocked sideways, semi-conscious, and in a very, very vulnerable state. So it is scary.
Yeah, and like I think what scared me when I found out the number of under 18s that are now in Cork that were actually using hard level drugs is absolutely mind-boggling. It's like when I was younger, Dr. Doran, this is going back about 10 years ago now, 12 years ago, because I'm 26 now, and I remember like hearing that like cocaine, ecstasy, and MDMA, that was like very, very hard to get back when I was younger. But now it's a case of you only have to kind of turn on Snapchat and you can see people selling it. Like there's no kind of like, how would I put this now? There's kind of like there's no real kind of regard for um the law around it anymore. It's kind of like blatant disregard for it.
Yeah, I would agree. I mean, any any town and village in Ireland, you can access these substances perhaps more easily than you can get a packet of Solpadeine in the pharmacy. So, and I'm not saying that pharmacies should give out Solpadeine more frequently, not at all. It's just put things in context, and it is worrying, and it's sad, really, very sad.
It is, and like for you as a doctor, it must be very, very challenging to have to kind of deal with such an increase in stuff, like the increase in like narcotics being used, because like main purpose of primary care is to ensure the wellness of people. And when people kind of go away and do silly things such as this, it must be very frustrating. People undermining and you getting them better for them to go away then and go on an absolute bender and undo all the work that you've say done over the last 3 weeks of them and getting them better off a chest infection or whatever.
Oh, absolutely. I mean, as they say, the World Health Organization of definition of health is not simply the absence of disease. And unfortunately, human nature being what it is, I've been to cases where we have resuscitated someone and reversed, say, an opiate overdose with naloxone. And some of the patients would become, very hostile because we've just wrecked their trip. And so, would decline further medical treatment and go off and source the next dose of whatever they're taking. So it is, as I say, frustrating and sad. And you're left there and looking after, quite often very young and vulnerable people.
And like, I think like, I was talking to an AP buddy of mine and he said it to me. He said he reckons that back within the next 5 to 10 years, he said this to me the other day when we were out for a cup of coffee. He said, Jack, he said, I wouldn't be surprised with what's going on in the world. He said, if FEC start giving emergency first responders nasal naloxone in the next 5 years to deal with the amount of overdoses that are going on at music festivals. As he said, it was crazy. He said the amount of overdoses he dealt with at a music festival this year.
Oh, absolutely. And I think, naloxone is being supplied to numerous groups of people who are in contact with, opiate overdose already. And I think that's only going to become a bigger need and requirement.
Yeah, and like it's absolutely mind-boggling how these drugs have taken over the country. But look, we have to kind of we could go down the rabbit hole about drugs for an hour, so I'll try and we'll start veering away from drug overdoses and stuff, and we'll finish up now with a few more light-hearted questions. And I just want to ask you, Dr. Doran, in your many years of experience as an emergency response doctor and as a general practitioner, what's been the best call you've ever responded to in terms of there being the outcome being absolutely fantastic? If you wouldn't mind sharing.
Okay. Well, there've been a number. Put it this way, just to go back to the darker side a little bit. And as I was saying before, in the noughties and before that and since, we've had a number of people who have harmed themselves. And, we've had at least 6, if not 7 cases where people have tried to kill themselves, and we have, responded and successfully treated them to the point where they have been discharged completely well with no neurological deficit and returned to the community. And the majority are grateful to have another chance at life. And as a sergeant in the Gardaí that I worked with formerly, said, that unfortunately deliberate self-harm is often a permanent solution to a temporary problem. And so lots of work still to be done in terms of mental health.
Definitely. And like me, myself, I don't balk away from mental health issues because I suffer from what I call the triple threat of anxiety, avoidant personality disorder, and I'm waiting for a diagnosis of ADHD. So I know myself that mental health issues can absolutely be debilitating, and they can absolutely be frustrating for an individual such as myself, and they can make you feel powerless at times. And I think the best thing about I think we're very, very lucky in Ireland is the outstanding levels of professionalism of GPs in Ireland. And I think for me it's brilliant because like when I started having these issues when I was younger, I went down to Dr. Kelleher, and Dr. Kelleher was a brilliant advocate for these mental health issues, and he made sure I got all the help I needed, and he's still helping me make sure I get all the help I need. And it's absolutely fantastic to have GPs such as yourselves advocating for people such as myself with mental health issues, and not afraid to kind of bring it up and say there needs to be more done for mental health issues. But it's absolutely brilliant when someone that has a mental health issue is able to live a nice, full, long life, and that they're able to get treatment for a temporary issue rather than using a permanent solution. I think that's an absolutely brilliant way of looking at it, Dr. Doran.
I agree totally, and it must be borne in mind as well that, as I said, 40% of people we would see each week would have some degree of mental health issue, and the majority we manage in primary care, and so the number of people who are referred on is small in comparison to the overall presentation of mental health issues.
And I just want to ask you this question. This will be our final question for today, folks. If you were to speak to a bunch of fresh-faced medical interns that are about to start their first hospital placement, they don't know what specialty they want to go into in medicine, and if they're listening to this podcast, which I hope they will, because this has been very, very informative, not just for me, Dr. Doran, but I think it'll be very beneficial for the broader community as a whole listening to this about just how valuable an asset ECRR is, and just how much of service you provide to the entire region of Cork as a whole. That what advice would you give to a student doctor kind of that's looking at going into medicine but doesn't know what specialty they want to pick?
Well, the first thing I would say is take your time, experience as much of the different specialties as you can, and just be like a sponge. Don't be in any rush to go down any particular route. And if you're not sure, it's always valuable to do some more medical jobs, particularly renal medicine, and just take your time to make your mind up. But overall, just, it can be stressful, it's demanding, but it's highly enjoyable and rewarding. So I would just say, enjoy yourselves.
And I think that's a very good bit of advice to give them. And that's what I always say to people as well. Because I used to be a chef before I went back to college to do government and political science, as I was a chef. And I always used to say to new chefs coming in, learn as much as you can. Don't be afraid to ask questions. And if you have questions, don't be afraid to ask them, because if you don't ask, you're not going to learn. And what I learned as a chef was, if you asked, 9 times out of 10, people were willing to share their knowledge with you to make you a better chef or a better, in your case, asking a question will actually make you a better doctor or a better physician.
That's absolutely true. And as you say, keep your eyes open, listen to, have situational awareness when you're dealing with any case, and listen to people who are, who have more experience than yourself. And, I've experienced where some of my colleagues would have said to a paramedic coming in, look, I'm the doctor, I'll decide. And that's shooting yourself in the foot. I think keep your bandwidth broad, and listen, and that will reduce the stress and also make you a better doctor.
Yeah, definitely. Folks, this has been our interview with Dr. Hugh Doran, the primary response doctor for East Cork Rapid Response. Dr. Doran, thanks so much for coming on today. And we've been very lucky to have you on, and we wish you all the best.
Thank you very much. It's a pleasure. Thank you.